I'm talking on behalf of Mr. Krishnagiri, who was supposed to be here, but because of a little bit delay in the program, he has to rush for something else. So a substitute will work only like a substitute, friends. He cannot become a master. So ignore my small faults in the presentation and in the conversation. But a small background is that I served 5 years in Government of India and Ministry of Healthcare before joining Accenture. So public health experience, I have little bit. But from the private healthcare, I'm sorry, I don't have much. On the front of the paradigm shift in terms of the healthcare, few concepts which we want to share with you is basically looking into giving a statistics picture from the background information. If you see the expenditure that we do in terms of the healthcare, overall expenditure is around 4% of GDP. Overall expenditure, including private and public both. But public expenditure is something around 1.3% of GDP, where the government and the industry is looking that its expenditure should go up to at least 3% of public expenditure and maybe 8% or 9% overall. Now this number, if you compare with Sri Lanka, if you compare with Thailand, we are far, far behind. Just to give you a glimpse of the issues that is happening around, and if you see what are the initiatives that have been taken is from the National Rural Health Mission, or we talk about of the budgets that have been declined for various other schemes and programs, both central and state government, some of the tertiary hospitals which are being modernized, and how all those elements are bringing in picture in terms of the programs and the success for the people in the country. But still, birth attended by the skilled health personnel, 19% poorest. And if you see number of indices or the parameters, you will find there is some benefit. I think huge way to go forward, huge way. Be the Millennium Development Goals that we need to achieve. If you pick up from the rural to the urban side, and you will find that the lifestyle diseases are also changing the shape, where the largest number of patients that are coming forward are coming from, let's say, the diabetics or with issues like cardiac arrest and other stuff. The young population because of the stress in urban areas and all. So you find the shift in the disease pattern altogether. You define the urban healthcare phenomena totally different and the rural healthcare phenomena totally different, where the primary healthcare is much more required at the grassroots level, but you find the life pattern diseases, you find a different level of prevention and cure methodologies, both for urban and rural areas. And if you see the healthcare spend in India and out of pocket, this is a pretty well statistics being defined every time in every of the conversations or dialogues that 80% of the expenditure is out of pocket. What I'm trying to reflect is not 80%, I'm actually reflect is the 3% insurance cover. And today, this is the way the inflation, the way the earnings, the way the expenditures are rising, and the way that we are seeing looking forward, 3% is actually very, very less. And this is a one number which reflects that huge amount of potential is there for both collaboration between the private and public enterprises. And I will focus a little bit more on that stuff later on. And the answer is that is the developing world is facing a problem, or is it something like the globally also? Friends, last elections, Mr. President Obama talked about of healthcare reforms in US. He couldn't succeed in that much from latter way. So the developing world not alone is there. Developed world is also looking forward to major reforms in this. The point here is coming out from this statistics is India has an opportunity to leapfrog some of those challenges which the developed world has faced earlier. And we have in a stage where huge amount of infrastructure investment has been done in the last 7 to 8 years. Can we leapfrog from now towards more of service delivery levels? And I just throw some more questions on that. A great effort done to articulate the right to education, ladies and gentlemen. I think it's the right time when we talk about a right to health. There's a constitutional right, fundamental right called right to life. Actually, right to life includes right to health. But specifically articulating right to health means what? And in my layman language, in the layman language of understanding of this concept, we find the three important pillars describes the right to health very importantly. One, the affordability of the healthcare. And second is the accessibility of the healthcare. And third is the quality of the healthcare, which is most important parameter. If these three things are clubbed together, some sort of right to health can be assured to the countryman in India. But how we do this exercise? Is it possible? Some ideas and some thoughts that we have. would like to share with you. I just want to quote, recently I was in the World Economic Forum meeting in New Delhi, and I heard Dr. Naresh Trehan was talking about that he has been practicing allopathy a long period of time, but today he is convinced that there's a huge scope of merging the traditional medicines with the allopathy. If you imagine the huge amount of knowledge that we have, the investment that's required from the allopathic treatments also, along with if a parallel conversations takes place of merge the traditional medicines along with the allopathy, I think a huge business case can be developed in India where the scaling and the capital cost, scaling becomes easier and capital cost becomes lesser. Apart from this, what I also feel is the doctors, the providers, the healthcare providers are huge in number. Huge. If you go in any villages, you'll find someone who is practicing some of the form of traditional medicine. How we can bring them into a big network and make a larger pool of providers and make a technology which enables them to explore the knowledge, share the knowledge, and also sharpen the knowledge, which can help in terms of the prevention. I'm talking about more from the prevention path because I understand the cure is much more costly than the prevention. So how we can move forward for preventive care rather than looking the curative care, where this type of exercise can be done. So one is this particular angle has never been touched seriously. It has been touched, but not seriously to mix these type of things together. And I think it's the right time when India can start looking into this, which is like example of leapfrog, how you leapfrog the activities. This could be one step looking forward. There are several examples of public-private partnership. I remember one of the, Karuna Trust, for example, he's a great leader, Dr. Sudarshan, and a good friend also. He has actually picked up 16 public health, centers in Arunachal Pradesh, the far northeastern corner of India, and run it successfully. Beautiful examples are there. We need not to see examples in Tamil Nadu or Andhra Pradesh or UP or Madhya Pradesh. There are plenty of examples far, corners of the North India or overall India where you will find that beautiful public-private partnerships can be assigned to. Club together, if you see the examples which have been done by business models in various hospitals where low-cost models have been developed, another beautiful examples of public-private partnerships. But I will not say that these are sufficient or they are the great ones. Idea is that one important pillar of the affordability, accessibility, and quality is that the traditional medicines are combined together with the allopathy. The second important pillar that I'm talking about is of public-private partnerships to enable that particular right to health that I'm talking about. So how you do this exercise, I will focus a little bit more on this. One example which can be quoted is the infrastructure development on the airports. You are all aware that huge amount of, you see any airports in India today, you'll find beautiful airports, well designed, new technologies have been adopted. Today, if I see the hospitals, and if I plug in the thought saying that can we have infrastructure made available by the public sector, and it's basically leveraged by all the group of the people or consortium who can deliver the services from that infrastructure to the people in the country. The only agreement that required is a service level agreement. For example, if I see there was a level of agreement in infrastructure and airport saying that none of the passengers who will be standing outside the window more than 40 seconds to get his tickets done. So that's a service level agreement. Now, if you turn this around and say, see, any patient who comes to the hospital will be delivered a service in 2 minutes of time and outpatient 1. If this is a service level agreement that we can design in the PPP, you will find different level of engagement coming forward. So the traditional way of looking into a PPP projects needs to be now reinvented or revisited in terms of new technologies, and the agreement that needs to be looked upon are more of outcome based rather than the process based. So it will completely change the paradigm of the healthcare service delivery in India. That's the second point which I want to make through the slide. The another one is, some of the elements of interoperability. For example, under the NRHM or under the various hospitals, huge amount of investments is going forward in terms of IT applications and systems. But how you see, the HL7 standards being adopted all across the country. For example, the interoperability becomes very important. So if you want to make up an HMIS, which is currently running all across the country, sorry to say, it just cannot run, because the plug-in data are totally different formats. So if you want to make one system put in place, you need to have interoperability running all across the country. Some level of system needs to be developed. One example which I want to quote is, today we find the income tax returns in a very efficient way. Why? Because north to south and east to west, the data formats of submission of the income tax return is similar. And there's one central system which collects the data from every corner of the country, from every individuals of the country. Imagine if we have an authority who collects the HMIS data from the public and the private hospitals on one format. Imagine the importance of that authority. On an annual basis, a return had been filed, like an income tax return has been filed. Imagine the database which has been created with that, and how much influence you can make, or better policy that you can make around. So the totally reinventing in terms of the systems and process, but also looking into futuristic part is that whether this system will work or not. And I think the answer lies is that a whole lot of technologies are there. My friend Dr. Modi just talked about of SaaS-based applications and technology. These are another initiatives which we need to look upon. The fourth important pillar is what citizens want exactly. Is that what we want to see, that what citizens want, or whether we are actually estimating in terms of the citizens' rights? So today, whatever system has been developed so far, I appreciate that. I'm party of this. But I also feel that we have ignored some sort of citizens' expectations from us. And from the industry as a part of an IT, from industry be the health provider, or from a bureaucrat who is running the system design, the policies, there's some sort of elements that we need to plug in where we say we need to have, coming forward of citizens' expectations. I'm reminded of the last that I have left 3 minutes with me, but I want to say that I have already finished my presentation and my talk about it. So that's perfectly fine. Last but not the least slide which I want to focus is some of the great examples of the mobility applications. My session is not to talk about new technologies which is coming up. It's some paradigm shifts in terms of healthcare service delivery. If I plug in some of the thoughts on ICT enablement, I definitely can talk about of hours and hours how it can be leveraged for scaling up, for the dimensions of HMIs, for the dimensions of the preventive care, for the telemedicine, and blah, and blah, and blah. But today's session is more to give some thoughts on, can we make some sort of a right to health possible in India or not? Is there some live examples that we can see in India? Yes, there are. Is the way that we look forward for going forward in terms of adaptability of this? The answer is yes. Thank you, ladies and gentlemen.